Hi everyone. I'd like to start by acknowledging that we're meeting on Kaurna lands today and paying my respects to their elders past and present. Earlier this year, the World Health Organization released this report called The State of Inequality, and it showed that globally inequality still persists in most reproductive, child, maternal, perinatal, newborn health outcomes that were measured, and that women who experience social and economic disadvantage were at the greatest risk of poor health. Of all of the indicators that the report assessed, the widest gap occurred in the proportion of births that were attended by a skilled attendant, where this proportion varied by up to 80% between the richest and the poorest women. And the gaps in access to care in pregnancy and birth were apparent both between high-income countries and low-income countries, but also between the richest and the poorest women living in the same country. Here in Australia, which we know is a high-income country, almost all women who give birth have access to a skilled attendant, and yet we see persistent inequalities occurring in many reproductive and perinatal outcomes. And when we start to look at patterns of health inequalities in subgroups of the population, it is apparent that these inequalities are multidimensional. For example, this graph shows the proportion of low birth weight babies, so born less than 2.5 kilos, in a range of population subgroups in Australia in 2012. We can see that overall, around about 6% of births, actually quite hard to point from this distance, about 6% of births in about 6% of births, the babies were born low birth weight. And we can see that this proportion is much higher among women living in low SES areas compared with high SES areas. But also there are important inequalities that occur beyond the effects of poverty. So place of residence is important. We see in remote areas the proportion is much higher compared with major cities up here. Whether or not your mother was a migrant has an interesting effect. The proportion of low birth weight babies among migrant women is actually lower than the total Australian rate. But when you look down the bottom, we see that by far the greatest inequalities in low birth weight occur when you compare Aboriginal and Torres Strait Islander women to non-Aboriginal women, where the frequency is roughly double, so around about 12%. And when we look at trends in low birth weight in the past decade, you can see progress in reducing this gap has actually been very slow. So in this graph, the top line represents the proportion of low birth weight babies among Aboriginal and Torres Strait Islander women in a 10-year period. The bottom line is the proportion among non-Indigenous women. We can see that since 2000, there has been a small but significant decrease in the proportion of low birth weight babies, equivalent of, among Aboriginal women, equivalent of about a 9% decrease. There's been no significant change among non-Indigenous women, so we are closing the gap, but only ever so slightly. Part of this small decrease or small improvement in low birth weight babies among Aboriginal and Torres Strait Islander women is probably due to a very small reduction in preterm birth, which we know is a determinant of low birth weight. So since 2000, there's been about a 7% reduction in preterm births among Aboriginal and Torres Strait Islander women, and we've seen, and as Sarah alluded to, a very small increase, or perhaps not a very small, a significant increase among non-Indigenous women. So again, the gap is starting to close, but only ever so slightly. When we look at other indicators of reproductive ill health, we see a very similar pattern. So this is a graph for stillbirth. We can see among various population groups, we can see overall, I think the proportion is about 7.5% per 1,000 babies, much higher among those living in the most disadvantaged areas, higher among women living in remote areas, much higher in those women who smoked compared with those who didn't smoke. But again, the greatest disparity occurring when you compare Aboriginal and Torres Strait Islander mothers to non-Indigenous mothers, where the rate is around about 1.5 times higher. Now, I could put up the same graph for a number of other reproductive indicators, but the story is pretty much always the same, that Aboriginal and Torres Strait Islander women experience much greater reproductive ill health than any other population group. Now, there are a number of reasons for this. There are many factors that contribute to these poorer outcomes, and they relate to both social and behavioural determinants, but also the performance of the health system. Many are either directly or indirectly related to income, and we know that Aboriginal and Torres Strait Islander women are grossly overrepresented in the low income brackets. Teenage pregnancy is important because it's not only associated with an increased risk of poor perinatal outcomes, but it can also have a profound impact on life opportunities for women through disruptions to formal education. And teenage pregnancy is common among Aboriginal mothers. Around about 1 in 5 Aboriginal and Torres Strait Islander mothers in 2012 were teenagers, compared with around about 3% of non-Indigenous mothers. We also know that Aboriginal women access healthcare differently. They have very similar numbers of total antenatal care visits, but they're much less likely to access that care in the first trimester. So they're potentially missing out on some key health promotion and screening interventions in early pregnancy. And this poor engagement is probably in part reflecting services that are culturally inappropriate. We also know that Aboriginal women enter their reproductive careers in relatively poorer health. Smoking is a major issue, and as Claire pointed out, a major risk factor for poor outcomes. And in 2012, close to half of all Aboriginal mothers reported that they smoked during pregnancy, compared with about 14% of non-Indigenous mothers. There are also disproportionately high levels of obesity at young ages, which again Claire mentioned, the importance of obesity in determining perinatal outcomes. So this graph, we see, you can see the proportion of women with obesity across a number of age groups, and you can see that around about 30%, just here, 30% of Aboriginal women aged 18 to 24 in 2012 were obese, and this figure rises to 37% in the 25 to 34 age group. When you look at the figures for overweight and obesity combined, you see that close to 60% of women in both of those age groups were overweight or obese. And we know that unhealthy weight contributes to not only poor perinatal outcomes, but it can also contribute to an increased risk of polycystic ovary syndrome and also infertility. I just want to spend a couple of minutes now on this final point, which is sexually transmitted infections, as I think the impact of these infections on reproductive outcomes among Aboriginal and Torres Strait Islander women are actually very underappreciated. So chlamydia is the most commonly reported sexually transmitted infection, or STI, in Australia. And this graph shows data from national surveillance systems about the number of reported cases of chlamydia expressed as the number of cases per 100,000 population. And it's information for the years 2009 to 13. The blue line is notifications amongst Aboriginal and Torres Strait Islander people, and the red line is notifications amongst non-Indigenous people. You can see that over in the last 5 years or so, there's been increases in both of those population groups, but the notification rate among Indigenous people has been consistently 3 times higher. We see a similar picture for gonorrhoea, which is another STI. Again, although we see slightly fewer notifications than chlamydia, the difference between notifications amongst Aboriginal and Torres Strait Islander peoples and non-Indigenous peoples is around about 14 times. So notification rates for these STIs are highest amongst the very young people, and particularly high amongst those living in remote areas. And what I want to do now is just show you some data from a paper that we published earlier this year, which involved analysis of laboratory data for close to 13,500 individuals living across 68 remote communities in Northern Australia. It's a bit of a busy slide, but bear with me. So what we can see, here we have the proportion of those 13,500 individuals tested for STIs. Here we have the proportion of cases of chlamydia in males and females. This is gonorrhoea in males and females, and this is trichomonas, which is another STI in males and females. What you can see is that there's a strong inverse relationship with age. So the proportion of infections is high both in males and females in the very young, so the 16 to 19 and the 20 to 24 age group. So roughly 25% of females had a chlamydia infection in that 2-year period, about 20% had a gonorrhea infection, and over 30% in that 16 to 19 year age group, had an infection with Trichomonas. And in that 2-year period, when we looked at the prevalence of any STI, we found that a third of all women and 21% of men had either a chlamydia, gonorrhea or TB infection. When you look just in that 16 to 19 year age group, nearly half had one or more of these infections in a 2-year period. And these figures are just incredible, I think, when you consider that the very high burden of these infections is occurring at a time of peak fertility for Aboriginal and Torres Strait Islander people. Why does this matter? Well, unfortunately, these infections are very insidious. They're often asymptomatic. They often remain untreated and infectious for a long period of time. When they are detected, they're very easily treated, often with a single curative dose of antibiotics. We know that when they're untreated, they can lead to chronic pelvic pain, pelvic inflammatory disease, which are determinants of infertility and ectopic pregnancy. When they occur in pregnancy and are left untreated, we know that they're associated with an increased risk of preterm birth, but also other adverse outcomes like low birth weight. And despite all of this knowledge and knowledge for over 2 decades about the very high burden of these STIs in many remote communities, there's actually been scant research looking at their reproductive sequelae in this group. So as a first step towards understanding the impact of these infections on reproductive health, a few years ago we published some research looking at the occurrence of pelvic inflammatory disease in 5 remote communities in Central Australia. And these were communities where there's a known high prevalence of STIs. What we found is that in a 2-year period, around about 1 in 5 women presented, 1 in 5 women in the 14 to 34 age group presented to their health clinic with lower abdominal pain, which is the most common symptom of pelvic inflammatory disease. However, when these women are presented, there were investigations to either diagnose or rule out PID were actually poorly undertaken. So only 7% had a bimanual examination undertaken. Because of the known high prevalence of STIs in these communities, local guidelines actually recommend a very low threshold for treatment, and they support a diagnosis of PID based on symptoms and history alone. We found that 95 of those 224 presentations met the guidelines or were consistent with the guidelines for a diagnosis of pelvic inflammatory disease, but a documented diagnosis occurred in only 15 of those, and of those 15, none actually received the correct treatment for PID. So I just want to finish up by saying Aboriginal and Torres Strait Islander women are disproportionately affected by social and behavioural risk factors in their peak reproductive years, and there is also substantial room for improvement in the way the health system responds to their needs. This contributes to a high risk of poor perinatal outcomes, but also poor fertility. And really importantly, the factors that contribute to these inequalities we know are modifiable, which suggests that much of the inequalities that we see is actually avoidable. Thank you.